to the next slide, please. Welcome everybody to our seventh webinar in our resilience series. My name is Jill Gillis. I'm the portfolio lead for the primary care improvement portfolio within Healthcare Improvement Scotland, and I'm delighted to welcome you all to this webinar. We co-host these webinars with Scottish Government, and Michelle Watt, Senior Medical Advisor for the Scottish Government, will be facilitating the first session in this webinar, along with the Royal College of GPs, and Scott Jameson will be leading the second discussion in this webinar. So next slide, please. It's just a little bit of housekeeping for people to encourage you as much as possible to open the chat panel. And if you can all just mute, that would be great. I think that's third on my wee housekeeping list here. I know people are just coming in. If we can encourage everybody to ask any questions to the speakers in the chat panel, that would be really great. And we're showing on the slide there where you can access the chat panel on MS Teams if you're not familiar. As much as possible, can we ask people to keep their cameras off and yourself on mute, which helps with some of the bandwidth issues potentially. And also just a wee reminder to leave the meeting. Sometimes people think when they close the Teams down, that's them left, but you do just need to press that leave button. So next slide, please. I think everybody will have seen this one. It comes up at the top on a banner and it says that the webinar is being recorded. And that's to let you know that we will record this and we will share the link with those unable to join the session following this session. So, please, and just another wee reminder, those coming in, to pop their mics onto mute if possible. So the aims of our webinar series haven't changed. It is really to continue to learn from response to COVID-19 and explore some of the changes that we've made as we've begun to move forward, and to continue to do that by connecting and learning from each other. And we're really going to do that in today's webinar when we look at how we're delivering different types of consultation, and we've got a range of speakers today who are going to talk through some of the different types of consultations that have been delivered in response to COVID-19. Can we move to the next slide, please? So this slide here shows some data from NHS England and the Health Foundation, and it's highlighting in red it's the face-to-face appointments and the blue line is the telephone appointments. And you can see that rapid sort of increase, with actually the highest number of telephone appointments taking place in March 21. And I think I would be absolutely naive to think this is not known to all of you on this call. There is this huge surge in demand and real challenge in and around managing that demand. So I'm going to have conversations today around about how some of you are overcoming that with different types of consultations. The next slide, please, is just some data from the feedback from the His Citizens panel, which was conducted sort of towards the end of last year, beginning of this year, and we had response from the Citizens panel for around about 526 respondents. It was about 56% of the panel responded. And to really talking about the benefits and the changes that they'd seen in the way that health and social care is delivered. And you can see that 64% of respondents were willing to see a health or social care professional via online tools to help with health services to resume. 58% respondents were willing to see a health or social care professional over the phone instead of face-to-face. And 55% of our panel respondents were willing to update their information or their condition or well-being through an app or some sort of text or website. So that's just a wee bit of an insight from our Citizens panel. I'm now going to hand over to Michelle, who is going to introduce the first session.
Thanks, Jill, and hello everybody, and a huge warm welcome to another busy day in general practice, and thank you all for coming along and giving up your time today. Another opportunity in a busy and packed agenda to share and learn from each other, today particularly around consulting in general practice, and an opportunity really to hear from colleagues and peers about their experiences, and hopefully get plenty of information, guidance and links and everything else to follow, recognising that this isn't a one-size-fits-all. There are lots of different ways of doing things, but hopefully an opportunity for you to learn and explore. Next slide, please. But before we move on to the main agenda and the busyness of today, I was keen that we just take a little bit of time just to pause and reflect for a little moment, because whilst we're all busy recovering and trying to manage a system that's really, pushing demand through reduced capacity right now, the system is really straining, and really mindful of the impact that that's having on every single one of us. And this graph, we've shown it before in our resilience series, and it shows the phases of disaster recovery. And I think every single one of you will be looking at the graph and thinking about where you feel personally and in your practice on that graph. And I suspect most of us are very much around that bottom level and contemplating a really big climb out. I think we've heard it say a lot, the clapping has stopped, and we're all having to cope with really trigger events and thinking about where we are now, probably 15 months on, from what's been a pretty difficult year. It's been a really tough 12, 15 months for every single person, and no matter if you're a wife or a mother or a husband or a parent or a child or a patient, it's really just impacted us all. It's impacted our family life, our own personal lives, and it's asked us to cope with more than we ever really should do in our professional lives as well. So I just really want to take a moment for us to reflect on that before we crack on and do what we always do in primary care, and think about solutions, and not just describing the problems. But hopefully that helps to set the context. Next slide, please. So before we move on to today's discussion, sometimes pictures say it more than 1,000 words, and Charlie Mackesy has seen me through a lot of dark days in this past 12, 15 months, and hopefully this resonates with you too. So on to the big climb out, and I'm delighted to introduce our speakers for this next session. First, Cathy Kenmure, Primary Care Cell Co-Lead in Public Health Scotland. Cathy has a wealth of experience around general practice and primary care nursing, and has been working tirelessly to help lead us through, along with Linda Hamilton, her colleague, and the rest of the team around infection prevention control measures. And I'm absolutely delighted to announce to you today as well that Cathy will shortly be joining us in the Primary Care Directorate in Scottish Government as our new primary care nurse advisor, professional nurse advisor. So absolutely delighted to have her on board, and she's going to be climbing a pretty steep curve pretty quickly as well. So warm welcome to Cathy and Linda, and over to you, ladies. Thank you.
Thanks, Michelle, and firstly thank you to Linda, who's very kindly helped me prepare today's slide. It's going to be a very quick whistle-stop tour, so I'll go with no further ado, and I've got an extra minute, which is really helpful. Thanks, Michelle. So whilst we're in the pandemic response, the advice and guidance on infection prevention control within general practice and community-based settings will continue to follow the guidance set out in the Scottish COVID-19 Community Health and Care Settings Infection Prevention Control Addendum. It can be found in the National Infection Prevention Control Manual main web page, or via the links which are in the Public Health Scotland Primary Care Guidance or the Scottish Government General Practice Recovery document, and the next version is due out imminently. This guidance is continually under review, and the addendum is a live document and changed as new evidence and guidance becomes available, and further changes are inevitable, and it's useful to have a responsible person keeping an eye on the website or looking out for any changes within the practice. You may ask why we're all following what seems very precautionary approaches as we move down the levels, but whilst community prevalence may vary, the UK advice and agreement is that we continue with this broad brush approach for the moment. And also, what is the tipping point for change to a more relaxed positioned or specific to levels? And again, this is regularly being discussed with evidence always under surveillance and scrutiny with decisions most likely being made through a 4-nation agreement. Next slide, please, Debbie. Sorry, and the next slide. My apologies. We only have a few minutes, so I'm going to use the hierarchy of control, which is included in the recent update of Community Health and Care Addendum, and to highlight and explain some of the ways to assess and minimise risk within the practice. The hierarchy of control is a system that's used to minimise or eliminate exposure to hazards, and the idea behind is the control measures at the top, i.e. elimination, are more likely to be effective and predictive than those at the bottom. And in any setting, eliminating hazard and risk is almost impossible, and GP practices are no exception. So how can you use the hierarchy as a way of applying IPC precautions to reduce risk during COVID, and how can this be applied as we move forward to a more business as usual approach? The key way of eliminating risk is not by seeing anyone, and that clearly isn't a feasible option. So what does elimination control mean in practice? So you're probably doing a lot of this already, such as phone consultations near me, assessing patients remotely, especially where suspicion of COVID or respiratory symptoms exist. And there's one key elimination level that you can implement, which is not only eliminating risk from patients, thinking about staff and staff not coming to work if they're symptomatic. And this is a key prevention area. So I'm quite sure all of you will remember pre-COVID, many of us, if we had a cold or felt a bit rubbish, would come into work not to let the colleagues down, and that moral duty prevailed, but our thinking around this has changed, and it will remain a key control measure in reducing transmission. So working down the hierarchy, other controls to minimise risk when you do physically see patients, to consider avoiding or minimising direct touch and employ as reasonable a level of distancing and spending as little time as possible within 2 metres. So could you try to work a bit more from the side rather than face to face? So that can be difficult if someone is hard of hearing. Is the ventilation in your room optimal? Keeping the windows open to improve ventilation, although we appreciate the need for confidentiality during consultations. But if you can't open the windows, could they be opened for a time whilst cleaning or in between appointments? And whilst we're still in a pandemic response, cleaning frequency of the environment should continue to be increased across all categories. A minimum of 4 hours should have elapsed between the first daily clean and the second daily clean. Where a room hasn't been occupied by staff or patients, its first daily clean was undertaken, a second daily clean is clearly not required. Another way to minimise risk is considering whether you can use screens at reception for staff. Again, many have already done this to provide a barrier, which could also reduce transmission along with good adherence to the use of fluid-resistant surgical masks. Thinking about any reusable equipment. So for example, do you need to use your personal stethoscope or other items as often? If so, make sure they're cleaned after each use. And is there an option to increase the use of disposable items? Trying to avoid sharing items like pens, tablet devices with colleagues as well as patients, and even thinking about the kettle handle and cleaning regularly between use. So washing hands or using alcohol hand-based rub at the times you need to. These are both effective controls, but if not carried out appropriately, this can come with a risk, and important not to cut corners even when we're busy thinking I'll do that in a minute when the next patient comes into the room. Okay, so we're finally here with the least effective control use, which is PPE. PPE is a protective barrier between staff and an exposure risk. It does have a place and can be effective control if used correctly. It's considered as less effective means of controlling exposure than elimination because it relies on human factors such as staff compliance and using it properly at the right time, all of the time. And staff need to have the education and training as to how to put it on and take it off properly. Be mindful PPE can become more of a risk than a control when it is overused, especially gloves, which can be used as a safety blanket. So for example, you might see some of your colleagues using gloves that are not needed as it makes them feel a little extra safe wearing them all the time. And the truth is that this could be putting them more at risk as it actually increases the risk of infection to staff and patients. And regular hand hygiene or alcohol rub would be much safer. So please remember, gloves are not a replacement for that good hand hygiene. Gloves are for single use only, and gloves should never be reused, double gloved, decontaminated with alcohol gel, which could damage them. And look at the way that you remove them and always clean your hands after removing your gloves. There's a useful flowchart that can be accessed through the addendum and the links to Appendix 5 on glove use and selection. So a way to support appropriate use of PPE is by regular auditing to make sure good practices are sustained day to day. And PPE is the easiest thing to wear, so an unintentional misuse can easily lead to exposure or cross-contamination. Fluid-resistant surgical masks used by all staff when in patient areas and where can't maintain the 2 metres, and that also includes staff areas and remains important, and encouraging patients to wear their face coverings within the premises. So the take-home points are these principles discussed will apply as we move forward. They've maybe not given you all the answers you need, but the principles are key. And the lower tiers, including PPE, are still crucial for effective prevention control, and especially important when there's much more difficult to eliminate or not possible to substitute risk within that GP setting. However, it is essential to think of the other key areas and more effective ways of reducing any exposure within your team before you get to PPE. Always refer to the National Infection Prevention Control Manual as outlined at the beginning. And for those that wish to increase their understanding further, IPC learning is available from NES on the TURAS platform. I'd like to pass on to the next speaker, Wendy Calder. So Wendy's a practice manager in Montrose. Over to you, Wendy. Thank you.
Thanks, Kathy. Hello, everyone. I am a practice manager of 2 of 3 practices housed in one building in the Links Health Centre, which is a seaside town in Montrose, Angus. Next slide, please. Like everyone else, we rushed to close and lock the doors at the start of lockdown, but our initial lockdown measures were revised within the first 30 minutes. As you will see by the bottom picture, it was actually a 50-metre round trip from the furthest practice, and we've got 3 practices in our building, to get to the front door. We also share our building with an outpatients department, and there was no practical way for us to police the entry for patients to the building safely and deliver effective care to the patients. So unlocking the doors turned out to be less of a problem than we had envisaged. Where we were worried that people would attend unannounced with COVID symptoms, it was clear public messaging locally and nationally. This just didn't transpire. Next slide, please. So prior to COVID, one of our practices operated an open surgery drop-in system, and anyone was seen as long as they attended between 8 and 10. This didn't allow us to do care navigation to more suitable services with hindsight. And throughout COVID, our admin staff have worked really well to gather information on why people were calling, giving clinical staff fuller details, and where suitable to direct patients to services might have been more appropriate. But this was difficult at times as some of our alternative services were either closed or suspended, and it was more challenging for patients to engage with opticians and dentists, and particularly for our link worker or social prescriber, who found it harder to direct people to alternative services and throughout lockdown. So our GPs initially managed most of our calls by telephone, as most practices did. But beyond this, it's clear face-to-face appointment is more suitable for some symptoms. So we now offer direct appointing by reception staff for patients who have breast or testicle lumps. And at a recent meeting with our GPs and our admin team, we agreed that the GPs will scan their appointment list in the morning of people who've been appointed, and to have a look at the conditions that they're coming in with. And if the GP feels they require a face-to-face appointment, admin will be asked to appoint these conditions direct to a face-to-face appointment without GP triage, just asking about the patients if whether or not they have any COVID symptoms. We feel care navigation is most appropriate type of appointment is more important now than what it has been ever before. So moving a practice from doors locked to face is being regarded as an equal option to us, with telephone and near me will be challenging for practices, but we do see it as certainly the way forward. Also, as more and more of the population are being vaccinated, the risks are significantly reduced. And although Nico will talk more about MedLinks later in the webinar, both our practices have used MedLink, and one practice had been using it before COVID, but this has allowed us to continue reviewing our patients with long-term conditions and continuing care and data gathering whilst minimising footfall, and thus ensuring that we now don't have a backlog of chronic disease monitoring now that things have restarted. Next slide, please. So while we still get patients phoning us to ask if we are open. We've never really been closed, but news of any closure makes it round town very fast. But the fact that we haven't been closed has not been so fast to travel round town. Next slide, please. And on a different note, our social prescriber identified a need for our patients whose group had been suspended. So she had organised a small group of patients to volunteer and to tend to our practice gardens. So it was a win-win for us in terms that our garden is now blossoming, because you might see the two pictures to the left was what they were like before. Some had no plants or anything in it, but now our garden's blossoming while benefiting our patients who were not able to access groups. And while the group started off with a group of garden enthusiasts, it has then reached out to many more of our practice population. We now have someone who's a bookkeeper who is keeping a tally of what they spend. We've got a photographer who doesn't like gardening but wishes to come and take pictures. We have someone who comes along and paints our tubs. So this type of engagement at Firm's the leading position that we have in a small town, and we're pleased that now and throughout the pandemic that we have kept the doors of the Links Health Centre open and we have managed to engage with patients. Thank you very much. I would now like to pass back to Michelle Watts.
Great, thanks Wendy, and lovely to see the picture of the garden. That's certainly kept me going as well until the rabbits eat everything I'm trying to grow at the moment, but hey ho. I'm going to ask some questions of our panel, and all of you on the call, I'd be really keen to hear your views and comments in the chat box. So one of the things that Wendy described was the kind of practical challenges of buildings and just physical space and how we use it, and the importance of that front door, notwithstanding the really helpful hierarchy of controls and the principles outlined by Kathy, which I thought was a really helpful little slide. But I'm keen to hear from some of the panel members in your own practices. What's it been like in your front doors? So I wonder, Nico, you posted an interesting question that people coming into the practice also adhere well to risk mitigation and wearing masks, and that's certainly feedback we're getting from lots of practices. But what's your experience been around your front door?
Thanks, Michelle. No, we certainly have. I mean, our premises aren't terribly large, as you'll maybe remember from being in Tayside before. And we've heavily relied on volunteers previously to screen people coming in and give them directions and guidance, to the point, unfortunately, where the volunteers who'd been extremely helpful throughout the pandemic were, I suppose, relocated elsewhere and went back to a lot of them to their normal lives. So we really struggled, our staff, to adhere to the door as general practice became increasingly busy. So obviously, with quality improvement in mind, we set out a risk plan, looked at the hazards, looked how we could mitigate them, and I did little tests throughout, and actually just adapted our signage and the setup really based on patient feedback on, yes, where could they pick up the masks, where could they apply hand gel before, how could we decontaminate, how could they come in, at what point, where would they stand, where would the distances be, how would that affect the flow of patients in and out the building, how would that affect the flow of deliveries. Considering all those things, actually, it probably took us about a fortnight to try that over several days, and trying it obviously in days when there's enough staff. But since then, actually, patients have responded extremely well. I mean, they're adhering to it. They almost say it's a sign of relief. Coming in, this feels like a slight return to normal. But also, actually, it seems like we're more welcome here. Some patients commented, and from the staff's perspective, actually, it has made life an awful lot easier without any disadvantages. And we've been running that now for about 2 months, and it's working really well with increasing numbers.
Great, thanks, Nico. And it sounds as though you did lots of small tests of change. Let's plan it, let's do it, let's see how it works, and then move on to the next step, which sounds really good. The other thing that Wendy mentioned in our talk was the communication with local communities and how embedded, how much of an anchor we are in general practice in our local communities, and the communication with patients. I think you'll all be aware of the social media posts and the letters in the paper and all the discussion that goes on. But keen to hear how others have managed that connection with patients in the way that Wendy was describing, and I wondered, Adam, up in Shetland, how's communication with your patient groups been? How have you found things?
Sorry, can you hear me now?
I can do, yeah.
Yeah. So obviously, yes, we've had the disruption with COVID. It's probably a bit of a unique circumstance for us here because we introduced an online system, Ask My GP, which we'll talk about a bit later, at the exact moment of the outbreak in the UK. So it was quite unique in the fact that as everybody was expecting to move to different methods of communication because they weren't allowed out of their homes, etc., we had actually brought that platform in. So we found it a very, very smooth transition, and patients were more than happy to shift almost completely to online communication and phone consultations.
Thanks. So they knew what was happening and you were able to communicate that to them?
Yes, we kept the patients very well updated. NHS Shetland were obviously putting their information over. We used things like our Facebook page. We have a text messaging system set up for patients where we could keep everybody up to date with exactly what was going on. And it all went relatively smoothly.
Great, thanks, Adam. I'm going to pass over to Scott now for the second part of our session, but I'm really keen to hear from all of you on the chat today. Stick in the chat box what's worked well for you in your practice and what examples might you want to share. It may be gardening, it may be knitting clubs, it may be different ways of communicating. What's worked well for you? Have there been any circumstances where it's not worked so well, and what did you do about it? Please do share them because it's a great opportunity, because what might work for you might work for somebody else. So thanks everybody, and huge thank you to our speakers. I think lots to go away and think about, and what might work for you in your front door and in your wee garden. So many thanks, and over to you, Scott. Thank you.
Thanks, Michelle. Lovely to see you, everyone. And next slide, please. So yes, this next session we're going to cover 3 or 4 examples of what some practices and some partnership areas have looked at for solutions to the problem. And this was described to me at a recent LMC meeting by a very learned colleague as this is sorting this problem, which is perceived problem, is one a little bit like a racing team and cycling. It's incremental small gains, and certainly referring to it as patient demand sounds quite derogatory almost, that it's their fault that they want to contact us, and a lot of these solutions are within our grasp, and lots of changes that you can make within a practice can help manage the balance of requests coming in. Next slide, please. So it is a delicate balance that we're trying to strike with all of this, and there are lots of pros and cons to each of the methods that we're going to go through and discuss today. It's about trial and quality improvement, and Nico touched upon his methodologies there, but the same methodologies apply to all sorts of ways that you can improve things within general practice, and it's really important that we do so. Next slide, please. I discussed this concept at a recent webinar, which I'll maybe pop into the chat as well on long-term conditions. But just to take, for example, the long-term conditions stuff where we talked about splitting data gathering, and MedLink is a part of data gathering within long-term conditions, but data gathering can also be on the phone, it can be at CTACs, it can be in other methods. And by looking at long-term conditions in a new way, you can look at both data gathering in one side. And if we move on to the next slide, please. That data gathering could then in management, it could be management in person, it can be management on Near Me, and we'll talk about that later on. It can be group consultations. There's no reason that you can't have group consultations at the moment, as long as they're appropriately social distance, and it could be by phone. And we have to think more creatively potentially about how we offer these different options, because there's no doubt that they're very enriching to care, and patient choice is quite important. I think we have to start to think about things from the patient's perspectives, not only what we think we gain as a clinician, but what we think the patients can gain. And next slide, please. We need to avoid the clinician sitting on the end of the phone like this, or the patient sitting on the end of the phone like that. Neither option is very good for either party, and offering choice is really important. Next slide. In my practice, so it's a little bit small. In my practice, this is a care navigation chart that my admin utilize, and you know, the patient phones in, and they try, and the patient might have a problem they look up online on the new gp.scot website that we have, and they might come to a shared decision they'll come to a shared decision with the admin on the best outcome for the problem that they have. And understanding why the person is phoning is key to care navigation. But drawing this out within your practice really articulates the huge variety of different treatment options that are available. I appreciate they're not available in every practice, but we offer these as equally weighted options, be that face-to-face with a GP. We're now piloting routine slots with our pharmacist as well, which has been really good. We've got triages with all these different people, mental health support worker, social prescriber, and we also will directly signpost on to other services, first contact physio. We have oral care pharmacy first, a phenomenal service. Cellulitis and shingles now available, treatment at your local pharmacy. So next slide, please. To highlight the Alliance report, you can look at this online. The link is also there for that one if you wish to look at it. But there are some difficult parts to this Alliance report. This was, somebody remind me, maybe 1,500 people, 1,000 people were surveyed, random survey but done by Alliance for government recently. And some of the messages in there are hard to read as a GP. There are some really good messages as well. 1,000 people, thank you, Fiona. But there are some really good messages, but there are also some really difficult ones. And it's definitely worth, if you're in leadership positions within primary care, but even just as a practice, have a look at it. There are messages in there. Near Me is an option in my practice. It's a completely equal option, and you know, we're now up to 1,700, just shy of at the end of May there. We really enjoy Near Me in our practice. Our patients really like it as well. It keeps them safe. It keeps us safe. It's just an option we offer. We don't, you know, what's the best for their problem. We offer it as a choice, and that's really important for us. Moving on, next slide. So it's a balance. There's the race for care options versus the options that you can offer, and you have to take your time in developing these options, but they're absolutely the right thing to do. And I strongly support and congratulate my colleagues who are going to speak to you now with regards to the innovation that they've all had in developing solutions within their own practices. But offering choices is a really good way to get to the solutions we need to help manage the current backlog of work almost that we're facing within primary care. I will hand over to my colleague, Nico Grunberg. Nico's a fantastic GP within Tayside and great innovator with regards to quality improvement and inspirational colleague. I look forward to what he has to say today. Nico, I'll let you take over from here.
Thanks a lot, Scott. Well, what can I say after that introduction? I mean, I suppose the only thing I can add to that is I'm a GP in Forfar and work quite closely in Tayside with Scott. So really today I wanted to share some of our experience in using Medlink, particularly around long-term condition reviews. And if we can get the next slide, please. Just maybe a brief introduction about Medlink. What's Medlink? Medlink's an online clinical review tool, or advertised as such, based on the old QoF templates. Our interest rate was around the remote data gathering aspect of it, and it presents with a variety of clinical condition. It covers them, also some administrative issues and some consent issues, particularly around COVID-19 vaccinations. Why were we interested in Medlink? Well, this was during pandemic time, or maybe in between the two peaks. We were really looking at how can we safely do data gathering, assess some patients with long-term conditions, particularly respiratory ones. Both Jill and some other colleagues mentioned that patients actually want digital. That we're in a digital era, and we really want to continue that. And actually, patient engagement. We want patients to engage with certain conditions and certain groups. And care and support planning is key to us in long-term condition delivery, and we're always looking at ways to do that better. And we wondered if Medlink would facilitate that data gathering and actually empower the patients a little bit. Now, how does Medlink work? I'll do this very quickly. If you Google Medlink, you'll find the forms and the conditions covered. It's a very simple to use for patients and for staff. They simply message individually or bulk a text, email, or letter, a link that patients access. If you go to the next slide, in addition to that, there's some educational resources, there's some video techniques, some videos about inhaler techniques, other peak flow and so on. And there's also some lifestyle nudges actually that are very well laid out and have engaged some of our patients. And if you go on to the next slide, and thinking about that patient education, patient empowerment, there are these links that can be adapted that can be national. So again, to inform the patient and to look at these more value bringing interactions with clinicians. And if you move on to the next slide. So what have we done so far? So our experience so far is particularly around respiratory conditions. The product comes with a dashboard, so you can actually see what forms you've used, and certainly in sending out respiratory reviews online, patients particularly like this, and it's allowed us to not have to see. So these are patients that say yes, it's fine, and clinicians say actually this patient's well controlled, I'm not concerned. 50% of our patients we didn't have to review the asthmatic ones, and we get very similar, even higher figures when you look at some other conditions, when you look at blood pressure assessments, when you do look at medication reviews, particularly contraception, HRT, epilepsy reviews, and so on. Actually, you don't really need to see these folk if they're well controlled, and actually the patients love it, not having to take time out if they're stable and not concerned. With some other long-term conditions, particularly it's having more impact on the patient, stroke disease, CPD, kind of more complex things, we find it, certainly in my practice, we use it more as a preamble, getting the data gathering, getting the information if patients engage, and then bring it to the table in the discussion. Actually look, does that add the discussion? If you move on to the next slide, there's lots of other conditions covered. As you see, this is a neighbouring practice, so we've used it in a slightly different way. So it's covered far more conditions, from depression to health check to postnatal reviews, and there's lots of different options, so you can adapt it to your own practice. And if you move on to the next slide, so from an impact point of view, really the patients that obviously go through it love it. The feedback we get from them is that choice is key. Convenience is key, and certainly still during pandemic, actually, the word safety comes back quite a lot. We have noticed that patients that haven't engaged for yonks now suddenly do, and actually once you tie them in, they seem to. And actually we're having discussions, actually, does this add value? And we have conversations with the Medlink team. They've added this question to their review at the end, has this added value? And most patients actually say yes. Now we are going to assess that more formally. Impact on our staff, we probably need to divide this up into clinical and administrative staff. The administrative staff certainly have to do a little bit more data handling. Information comes in, it needs to be entered in the record. That has some time impact on them. But certainly for our clinical staff, the information is there, there's preparation, the focus of the conversation or the review is slightly differently. Process-wise, big change here. This is a choice, obviously this is an option for patients, so when you're offering this, you need to think about alternatives. This isn't for everybody. You need to integrate this into your protocols, into your recall system. You need to make sure patients aren't missed. So obviously that needs a review. Obviously that needs a whole team to do that. So as you're adapting your system, you need to look at it and improve it. And actually recently we've started to work with our health and social care partnership team, and our district nurses are started to use this and facilitate actually housebound patients and even care home patients taking part in this. And if you move on to the final slide, please. So really what we're working on now is actually facilitating some of that data entry for the admin staff. So we're making some vision guidelines. Vision is the clinical software we're using. We're looking really at, through our primary care network and Tayside, looking at assessing the impact of this more formally for patients. And then when we're doing all this, the whole purpose of this is to offer choice, to improve care, to add value, what's missing for patients, what's missing for us. And to me, this is really the start of a journey of having that digital information. What Jill said, patients are keen to be involved, patients are keen to look at their data, enter data. So for us, this is really a way to look at that. So that's enough from me. I'm going to hand over to Paul Bailey, who's a colleague from Lothian, who's going to talk a little bit about using eConsult.
Yeah, that's great. Thanks very much, Nico. My name's Paul Bailey. I'm a GP in Newbattle Medical Practice in NHS Lothian. I also work for 1 day a week for Midlothian Health and Social Care Partnership. Next slide, please. So I'm just going to speak very briefly about eConsult. I just want to quickly say that I don't have any pecuniary interest in eConsult. The practice received a small amount of funding as part of setup costs pre-pandemic, but I have no other declarations of interest. Next slide, please. So Newbattle Medical Practice, we're a very large practice. We're one of the largest practices in NHS Lothian, and our journey around or getting to eConsult has probably been very similar to many other GP practices. 10 years ago or more, we were allowing patients to direct book face-to-face appointments, and that worked very well for many years until we got to the point where duty doctor became very busy because the pre-booked appointments were all booked up well in advance. 2013, we were relatively avant-garde. In 2013, we introduced total telephone triage, and that worked very well for a number of years. The problem is that we weren't a demand-led service. We offered a capped service, and that led to patient behaviour, which meant they were all phoning in the morning, and it was difficult for people to get through on the phones, which led to complaints and actually poorer access for the patient population. It led to sort of random allocation appointments, if you like. So we looked at an alternative solution, which was eConsult. We asked our GPs whether or not they would like to use Ask My GP or eConsult. We went with eConsult primarily because it asks patients a lot of questions. That can be both a help and a hindrance, and we'll hear about Ask My GP a little bit later on. But the primary reason for us taking it on was about demand management for us. There are lots of other benefits. We believe it provides sort of an equity of access because our phone lines are still open, so it frees up phone lines for patients to contact us that way. It's a little bit about modernising your practice, having a digital front door. There aren't many things that you can do. You can't do digitally now, booking holidays, shopping, whatever it is. It's also a useful communication aid. We can message patients, and I use it as a messaging system, even after I've seen patients face-to-face sometimes, to give patient information leaflets and further advice, and therefore there are environmental benefits as well. Next slide, please. So I just want to show this slide. Primarily, like I said, we were using this as demand management, and this is our eConsult journey. The green line you'll see there is 2019, and it's the beginning of 2019, so pre-pandemic. And initially, you'll see the green line going gradually up. That was people just starting to use the service. And then the thick green arrow pointing upwards on that green line was us starting to channel all patients through eConsult. So even if they were phoning up, the patient would phone up, we would complete an eConsult on their behalf, and that would go to a GP to help process their request. And you'll see that line just started to go up very dramatically, and then that became the yellow line. The down line is where we turn things off, the 0 points where we turn things off over the Christmas period. But you can see over the yellow line, things gradually increasing. The thick red line was the first day that COVID was announced in Scotland, and you can see a surge in demand the week after that, and then the blue arrow pointing upwards is lockdown, so demand decreased, although not as much as perhaps you might think. And then throughout 2020, over the course of the pandemic, that's been the use of our eConsult. throughout the pandemic. And you can see as the lockdown has eased, and the purple line is now where we are in 2021. The key message from this is I think it's easy to assume that having a digital front door leads to a phenomenon of something called supply-induced demand. And I've spent a lot of time looking at this and looking at the evidence base around that. There is no currently good evidence that suggests that supply-induced demand exists. So I don't think we're seeing that necessarily. This may be COVID backlog, unmet demand, but we will have to see. Implementation is crucial. We're now on our third way of using eConsult as a tool in our practice, and we think we're getting it better now. But you can use eConsult different ways. So with the same tool, you can use it in different ways and get different outcomes. Next slide, please. I was asked to speak a little bit about patient feedback. On the right-hand side of the screen there's some key indicators that eConsult ask patients once they've used the service. I won't go through all of those, but that's an average of the feedback that we've had ever since the beginning. What I want to draw your attention to is the graph in the bottom corner. You can see when we first started that the feedback was very positive. Over 90% of patients were satisfied with the service. And then the green line, the thick green arrow there, is when we started to put all patients through eConsult. And that's when we started to get the people who were more conservative or the skeptics of having a digital front door, and the feedback became more negative. And then the red arrow, there on the graph is COVID. And then you can see that patients' feedback was more positive because patients were very appreciative of us having that digital front door there. Next slide, please. Next slide, please. Thank you. So the key messages are for us, it's been about eConsult is a fantastic triage tool. I think it is not there to replace either telephone or face-to-face consulting. It can be used as a messaging system or an e-consultation, but actually very few of the consultations we find end up like that. And for us, it's about efficient triage being the key. I've got links to another presentation that I've got on, which is a longer talk on implementation. And I also think that the QI toolkit on NHS Lothian's website is very good. So it's about efficient triage. Would any of us go back in practice? No. We feel as though with good triage, we're getting continuity of care with patients seeing the right person, right place, and at the right time. Thank you very much. I'd like you to now go on to Adam, who's going to talk a bit about Ask My GP. So thank you, Adam.
Thank you, Paul. And hello to everyone. Paul used a phrase in his presentation there about demand management. I manage the Lerwick GP practice in Shetland, and we felt that the demand was quite overwhelming, as I imagine a lot of people have experienced. It's definitely during recent times. We just felt that there was a massive wave of new patients that needed to be seen on the day, of pre-booked GP appointments, of trying to set aside time for our trainee GPs to have a tutorial time. And we felt it was very overwhelming. There was no space to get the patients in there, so we needed an overhaul of the system. Next slide, please. Next slide, please. Yeah, we can move on to the next one. Next slide, please.
Adam, if you maybe just keep talking and then we'll catch up.
Okay. This is very much how we felt. I think many people could associate themselves with complete gridlock. We had a wait of perhaps 3 to 4 weeks for a GP appointment. And we very much felt that we had to come up with some kind of system to kind of regulate the traffic. So this is when we introduced Ask My GP, just at the start of the COVID pandemic. The system is very user-friendly in that it's very much like the eConsult module. Next slide, please. It allows the patient to answer several questions that gives the clinician lots of information about their problem. Previously, the patient would only have had 30 seconds, perhaps, in a phone call to a receptionist to describe what they needed. Ask My GP allows the patient to access the system at any point, 24 hours a day, and to write as much as they possibly can about their medical issue. So we found that it improves access for the patients. We found it's brought our wait for a GP appointment down dramatically, as you can see from the information on the slide there. And it really gives the power back to the clinicians. We had an ongoing issue, which I'm sure many had, of this kind of disconnect between the patient not really giving much information. So we weren't really in a position to say which member of the MDT was best placed for that patient. But now with Ask My GP, we have all of the patient's information, and we have a clinician each day that can direct the traffic, that can say, yes, from the information that the patient has put down here, it needs to go to the physio, or it needs to go to our pharmacist, or it needs to go to our advanced nurse practitioner. So it really has put the clinicians back in the driving seat. Remote and rural view, it's a little bit unique, the situation in Lerwick. Although we are in Shetland, it's very much like a town practice. We have 8,700 patients. There are other practices in Shetland that have 2,500. Some of the smaller ones have 700, 800 patients. Our view on Ask My GP is that it has more of an impact in a larger practice, and more of an impact in a practice that is perhaps struggling to cope with the demand that it currently has. That's not to say it wouldn't be useful in some more rural practices. There are some in Shetland with several thousand patient list size that are introducing the system, so it still does have benefits for patients. Next slide, please. Some of the lessons that we have learned, as we just mentioned, clinicians feel a bit more informed and feel safer, that they have more information on a patient instead of a receptionist booking a patient in for a 15-minute appointment, and perhaps the patient doesn't want to give a reason for their appointment that day. Whereas if they go through Ask My GP, it asks them leading questions, it's amenable to them putting as much information in as possible. So our GPs, our AMPs feel a lot more in control. The bottom 3 bullet points that you can see on the current slide are just an example of some of the feedback that we get. The current feedback for Ask My GP in the Lerwick practice is a 96% positive rating. So that means that 96% of the patients that use it say that it is either a good or an excellent service, and they would recommend it to their friends and family. So that's actually been consistent from day one. We measure this on kind of a monthly basis, and it's always stayed at 96%. So we're not quite sure why it's not budged up or down, but we're happy with it. It's something that's very popular with patients. And the final slide, please. Just a couple of facts and figures. We introduced Ask My GP very much as an extra tool for patients. So we didn't introduce it and say, by the way, we're taking away some of the phone lines. We introduced it as an extra tool. Because so many of our patients have got on board and used Ask My GP enthusiastically, it has resulted in a reduction of phone calls. So we have been able to take away some of that admin staffing and redistribute it to other areas of the service. As we mentioned, the approval rating is currently excellent. And other practices, NHS Shetland has very kindly funded it for ourselves and other practices in Shetland. And it is really a system that you can evolve it. So it's quite adjustable. There are many different moving parts to it that you can tweak and change as you see fit for your GP practice. The conversation that is going around at the moment here is what is the next step. We've had many locums ask us the question, can we work for you remotely? So can we stay in Glasgow and log into Ask My GP and work remotely for you? So that is something that is being discussed. Ask My GP certainly makes it possible. And so we've had a very positive experience with the Ask My GP system. So thank you for listening to my presentation. I'm going to hand over to Scott Jamieson.
Thanks so much, Adam. Hopefully, we are going to be able to watch Duncan McNabb, my colleague, wasn't able to attend today, but just to give a slightly different perspective on eConsult, we have a different take on it because the utility, as was outlined there by Adam, in different places is important. And if you're keeping track of the chat, it's really important as well here with regards to these are things that practices have chosen to do themselves or within partnerships. The government are looking at this, whether this should be procured nationally as well. But Duncan, do you want to just play Duncan's thing? Is that okay if we can go ahead with that? Hopefully coming soon. I'm not getting the sound as yet, guys. If not, well, we just have a, okay, we've missed out on Duncan. We'll maybe try and post that link to that in the resilience webinar chat then. Can it be procured nationally, Fiona? That's a good question. So the procurement of the digital asynchronous consultation came from a letter, I think, that the GPIT committee wrote to Scottish Government to ask them to do that as a priority, that's now been looked at. Of course, it would need to be budgeted for and need to be considered that way. So government are aware of the existence of it, and it's been discussed with them, and our feedback has been discussed with them on it, but whether they choose to do it is up to government and up to us to raise it as an issue. Certainly we found it very beneficial, the fact that it was purchased for us in Tayside, but that doesn't for us in Angus rather. That doesn't mean that it's free for everyone. I just was wanting to pick up on some of the themes there of the choices, and I just wonder whether in the closing kind of minutes or two, I wonder, Wendy, as a kind of another practice manager, you were talking about the door being opened, and it touched upon some of the choices being offered within your practices within Montrose. Do you think patients cope with the choices, and how do admin manage that, and what are the methods you've used to try and make that possible? Because I think the days of everybody phoning and all care being through appointment with a GP are probably gone, and certainly I'd be frustrated if one of my 15-minute face-to-face appointments was utilised for something where I'm really not the best person to help sort that. Wendy, have you any comments on that from your perspective as a practice manager? Wendy, if you're sitting having your lunch, you missed out, and if not, we can move on to Adam to then answer from a practice manager's perspective instead. Never mind, Wendy's doing something important. Adam, from a practice manager perspective, anything?
Sorry, can you hear me now? My team's just dropped out a second there. Can you just repeat that?
Yes, we have. Adam, I was just wondering whether, from a practice manager's perspective, how we're finding the variety of choices being offered. Certainly, it's difficult enough for practices sometimes to keep up. How are the practices manage it, and admin in particular? How are we getting that communication with patients across?
Yeah, I mean, it's like with anything, we're quite thinly spread here. So we do find that we go through times where, yes, patients don't feel as well communicated with. I've just been watching some of the comments from earlier, and I think the theme that's come through is definitely to try and use things like social media, Facebook, Twitter, to get your messages across to patients. And that's something that we are trying our best to do. One of the things we fall down on a little bit is our website. because these days, if people want to use a service, they go straight to the website, don't they? So I think that's something we need to pick up on. Some of the practices seem to be using their websites very, very well, and I think that's what we need to focus on.
Yeah, we participated in this little pilot they're doing with the gp.scot platform, and we've just tried that just now. So it's not perfect, and there are bits of the navigation that need to be tidied up, but you can develop these yourself. I'll put a link into, that's the way my practice website looks on it. And you need to click on that top left Our Practice button for you to get into anything. So there's bits of that need to tied up, but there is a way to that other practices can look at that and pilot it themselves to try and develop a website. I can't find the link for the life of me, but somebody will find it. With regards to the question I saw as well in the chat about indemnity, Neil, I mean, it's no different really to asynchronous consultation with regards to MedLink and Ask My GP and GP at Hand and other similar things. They're all asynchronous consultation methods. So Indemnity have been involved in all of those companies get MDDUS and MDUS input into them, and certainly it's there's huge amount of data protection and governance protection surrounding them, and a lot of these have GP involvement with them as well. So listen, I'm going to wind up there and hand over to Jill.
Okay, Scott, thank you. Can folks hear me okay? Thank you very much for a fantastic discussion in the chat box there. Really amazing, some of the different sort of adaptation and adoption of different solutions and flexibility and choice coming through so strongly. So we will share all of the links. I'm going to quickly pass over to Mark Bizik from NHS Near Me, who had come in with an announcement around about their new toolkit. So Mark, if I can hand over to you for a few minutes before we wrap this up.
Absolutely, yes. Thank you, Jill, and thanks everybody else for this afternoon's insights and inviting me here. So basically, I want to share with you some learning. We undertook some regional GP webinars in the early part of this year, and what the things we learned from our practice staff and also the people attending us was the key role that the admin staff, the admin teams who are fronting your conversations with patients, have in the role of care navigation and the offer of choice for patients phoning in or requesting help. And what we did then was look at how do we engage with that group, that sector of the workforce. So we did a webinar with them around, what are your needs around Near Me, choice and care navigation to support those decisions for the help people need for phoning primary care. And out of that came the request of some kind of quick, easy to read toolkits or quick start guide for Near Me, and how does that conversation fit with care navigation or MedLink or eConsult? Where does it all fit? So we're in the process of putting together a quick start guide for practice administration staff teams to help them work through the Near Me offer for people as they contact practice. We're just to the point of selecting 5 practices to pilot this with. We've written it in conjunction with some practice managers, some GPs and some reception staff. We want to pilot it as quickly as possible and then get it out to folk for you to utilise as part of the ongoing sort of recovery for primary care, and support you as much as we can with the choice of Near Me for patients. So happy to take questions. And also, I think they're going to put some links to our tech website where the current Near Me guidelines are and resources, and also the general practice primary care guidance for Near Me too. So that's all I wanted to say. Just watch this space for some support resources for your practice administration staff. Thank you, Jill.
Brilliant, thank you, Mark. And I'd see in the chat, Fiona's been saying that we do need more support for practice managers to implement and maintain all of these things. And great to hear we're getting that from Near Me. And it certainly looks like that's the intention from Fiona Duff's group around about the asynchronous consulting as well. As how do we pull some of the learning from these implementations together and begin to share? The slide just in front of you is just showing you the range of topics we've had in our webinar series to date, and really just wanted to remind you that we base these topics on your feedback. If you move to the next slide, please, Debbie. And that is coming through the evaluation, and we pop that in the chat box, so please do fill in that evaluation and let us know what you want to discuss in future webinars. Following the feedback at our last webinar, we are looking to host the next webinar on long COVID. We were in the planning session yesterday for that. It's looking like a jam-packed webinar, which we'll hope to host in and around mid-August. So we'll be out to you with the date for that one, and we will send all of the links into the documents discussed today in a follow-up email. Thank you to all our speakers. It has been absolute jam-packed, and apologies we have run over by a few minutes, but thank you for joining us, and have a good afternoon.